Hi everyone, my name is Faraz. I'm one of the PGY3 here, and I'm going to be talking about biliary ultrasound. Just want to say thanks to Dr. Allen, Dr. Lee, Dr. Walsh, Dr. Kilpatrick, Dr. Tannison, Dr. Lee. So the objectives of today, so this is a pretty I guess entry level lecture on biliary ultrasound, I guess more aimed towards the juniors. We're going to go over the basic background and indications for biliary ultrasound, go over some of the anatomy and techniques, and then differentiate normal versus abnormal. And then we'll just touch briefly on some studies going over test characteristics and where measurements come from. So biliary ultrasound, we were talking about biliary disease, a lot of which stems from gallstones. So the different biliary diseases that we're talking about, what we look for on ultrasound is just plain cholelithiasis, which we have to differentiate from just biliary colic versus acute cholecystitis. We can see choledocholithiasis, and then in the right clinical context, and I guess more rarely would be ascending cholangitis. So just some background about about biliary disease. So it is actually the third most common cause of abdominal pain in the ED. You can't differentiate biliary disease from biliary colic with just lab studies or your history alone. You do need imaging for that. And then bedside ultrasound can detect cholecystitis as well as choledocholithiasis, and has been shown to reduce length of stay in hospitalizations. So the breakdown of this presentation, I wanted to go over the model of IAIM, which is a model for bedside ultrasound. So it's an acronym that stands for I is indication, basically choosing the right study for the appropriate reason. A is acquisition, making sure you obtain the appropriate image that is a good quality image and it's everything that you need to interpret. I is the interpretation of that image. So not only do you have to take the appropriate image, but make sure you understand what your image is showing you. And then the last part is M, which is the medical decision-making regarding that image. So not only did you interpret the image appropriately, but you took the appropriate steps in management afterwards. So first, we're going to talk about the indications. So I wanted to ask the juniors, what are some indications for doing a right upper quadrant sono? You can just shout them out. Yeah, good. Right upper quadrant pain. All right, any other indications? Yeah, jaundice is a good one. Fever is a really good one, especially in the patients who you have in the ICU that are kind of comatose. You can't really tell if they're having pain or not. They develop fever. You don't really have any other source. That could be a good one. So yeah, we hit on the main ones. So yeah, vomiting, nausea, right upper quadrant pain is an obvious one. But for things like biliary colic, the pain's actually not very well localized because you're having some visceral pain. So you can have pain in the right upper quadrant, but then you can also have generalized abdominal pain. You can have back pain. So those can be indications. Also for epigastric pain, you think of pancreatitis, but it could also be a good idea to do a right upper quadrant sono to detect if the pancreatitis is caused by gallstones. So just going over some of the anatomy. So in this picture, it's important to note that the gallbladder is actually retracted. So normally it'll be lying closer to here, but it's retracted so you can get a better view. And why I chose this one is so that you can see the portal triad, which will be important later on when we go into identifying it on ultrasound. So over here, you see the portal vein, the hepatic artery, as well as the common bile duct. Also important to know, I know this is basic anatomy, but note that the duodenum is right here. We'll go into why that's important later on. So image acquisition. So the first step is to identify which probe you need. So in this situation, we'll be using the curvilinear probe or the abdominal probe. The reason you use this is because it has lower frequency and therefore greater penetration to get those deep structures in the abdomen. In certain situations, it might also be helpful to use the cardiac probe, especially if you can't get the image you want, if it's in between the ribs and the curvilinear probe is too big for that. You can also use the cardiac probe. So the techniques, there's multiple different techniques on how to find it. There's no like one right way. You do whatever is comfortable for you and helps you find the image. These are some of the techniques to get you started. So the first one is a subcostal sweep. I don't have any videos for that, but just verbally explaining, it's basically you go underneath the costal margin and kind of sweep along the edge of it until you find the gallbladder. Another one is the X-7. Basically, you find the xiphoid process. You go 7 centimeters to the right and identify it that way, and then just move around appropriately. The last one, they call it flattening the probe, but basically you go again underneath the subcostal margin and you, what's it called? Fan through from top to bottom until you get the gallbladder in place. I actually use a different technique that was taught to me, which is basically starting in Morrison's pouch and identifying the inferior portion of the liver and then kind of sweeping along the liver until you hit the gallbladder. So the best way to find the gallbladder is honestly just through practice. You can use any of these techniques, but find whatever way works for you. Okay, so what are we looking for on these studies? Again, juniors, what are some things that you look for when you're looking for the gallbladder? Good. Yeah, so sonographic Murphy's. Wall thickness, good. Free fluid, yeah, that's a good one. I'm sorry? Stones, good. Yeah, so you guys hit most of them. Yeah, you want wall thickening, pericholecystic fluid. You also want to look for CBD dissension, and then the sonographic Murphy sign. So the sonographic Murphy sign, for those of you who don't know, basically you're looking for the point of maximal tenderness to be over the gallbladder. So you get the gallbladder fundus in view and then press down. If that is more tender than anywhere else, that's considered a positive sonographic Murphy sign. So now the views themselves. So this is a longitudinal view of the gallbladder. In this view, you have the indicator pointed towards the patient's head. And then you very clearly see the gallbladder here. You don't really identify any stones. The important thing is this is a still image. In order for you to have an adequate biliary study, you need to take clips, basically fanning through the gallbladder from top to bottom, side to side, in both views. So this is a longitudinal view. And then this is a transverse view. So you again have the gallbladder in view here. And then in this view, you're also seeing the portal triad. So like I said before, over here, you're seeing the portal vein, the common bile duct, and the hepatic artery. So for this, I showed you the anatomy before, and it's laid out in the same anatomical plane. However, it's not always like this. So the way to differentiate the hepatic artery from the common bile duct, you need to use color to see if you're having any like arterial flow versus nothing should be flowing in the common bile duct. In up to 15% of cases, the common bile duct and hepatic artery, the anatomical locations would be reversed. So that's why it is important to use the color flow. So going over just interpretation. So I just wanted to go over some of the normal measurements and what's abnormal. So the normal measurements, so obviously you'd see no stones, you'd have no sonographic Murphy sign. And then these numbers actually change from study to study, but generally for the gallbladder anterior wall, you want it less than 3 to 4 millimeters. You don't want to see pericholecystic fluid. And then for the common bile duct, again, this changes from study to study. I've saw numbers between Basically 4 to 7 millimeters. You want it less than that. So depending on the clinical context, you can adjust accordingly. It also depends on age. So in this study, they're talking about less than 4 millimeters, but then for each decade above 50, you add 1 millimeter. Another study showed less than 6 millimeters is normal, but then above 60 every decade, you add 1 millimeter. So what to look for gallstones. So in this picture, you see, so the hypoechoic region, this is all bile. That's what generally gives the gallbladder the hypoechoic imaging on ultrasound. However, you're also seeing sludge here, which is generally made of crystals and cholesterol, and can be a precursor to stones, but they are different from stones. Sludge is different from stones. Over here, you're seeing the stone itself, and what differentiates this from sludge is the acoustic shadowing that you're seeing. Generally, for the acoustic shadowing in gallstones, it's pretty uniform, versus you'll see shadowing from bowel, and that is what they call dirty shadowing. So it's not as uniform as you see from gallstones. Over here is another example. You see a large stone, and then you see the shadowing. Then over here, you're seeing many stones with the shadowing. So then we'll talk about WES Sign. So essentially what WES Sign is, you see a contracted gallbladder over a stone or a collection of stones. So because of that, you don't see the posterior wall of the gallbladder. And that's normally because the acoustic shadowing is covering it. So what WES stands for is the wall echo shadow, which you can see clearly over here. So you have the wall of the gallbladder, you have the hyperechoic image of the gallstone, and then the acoustic shadowing. So you're not seeing the posterior wall of the gallbladder. So stone and neck is an important finding. The reason, so when you're doing a gallbladder study, you want to make sure that you're visualizing the entire gallbladder, including the neck, because that's where, if you're having pathology, that's where you'd find it. So the stone and neck sign, which you see here, you're basically just seeing exactly what it describes as stone in the neck of the gallbladder. When you see this, it has a 97% specificity and a 93% positive predictive value of diagnosing cholecystitis. And there can be a number of gallstone mimics. One of the most common one is a polyp. So the main difference here, you see it's kind of circular, it looks like a stone, but the most important thing that you'll notice is that there's no shadowing of the polyp. And then it's harder to tell even when you take clips, but generally polyps are going to be immobile versus gallstones. I know we basically take them in one clip, so it's kind of hard to see. But if you move the patient around, gallstones should technically also move around. So the next abnormal finding would be pericholecystic fluid. So over here, you generally see pericholecystic fluid between the gallbladder and the liver. So over here, you're kind of seeing the hypoechoic fluid around the gallbladder. And then over here, it's not, you can kind of see it along the edge, but you also see it over here. Again, this would be abnormal finding. So gallbladder wall thickening, we talked about it. So 3 to 4 centimeters, or sorry, 3 to 4 millimeters or less is considered normal. So greater than that in the right clinical context would be abnormal. So there's a number of things that can cause the gallbladder wall to be thickened. One obviously is acute cholecystitis, right? Anything that causes inflammation, but then also just when you have a lot of fluid accumulation. So anything from like ascites, CHF, nephrotic syndrome, renal failure, and then even multiple myeloma or HIV. These are all things that can cause gallbladder wall thickening. So you want to make sure when you take that measurement that you're taking it at the anterior wall. And then just like this example right here. The last abnormal finding that we're going to talk about is the common bile duct thickening. So over here, you want to get the common bile duct in view, like I previously had mentioned. You're seeing the gallbladder highlighted in green. You're seeing the portal vein highlighted in orange. And then in pink, you see the common bile duct. So this outlines it nice for you, but generally you won't have these colors when you're actually doing the ultrasound. So how you differentiate, like I mentioned before, is you do color flow. It might be hard to see, but over here, they do color flow. You can see the two structures. And then right here where there's no color flow going, when it pops on the screen, that is the common bile duct. And then the last one, this is like fairly obvious, but you can clearly tell that the common bile duct is distended. You also have a stone in the common bile duct. And it's important when you're taking the measurements that you do inner wall to inner wall. So what are some pitfalls? So failure to identify the neck, like I said before, it's important that you get the entire gallbladder in view. You can easily miss stones if you don't identify the neck of the gallbladder. Another important thing is the inability to locate the common bile duct. I know it is a little bit more difficult to find, but it is important to find, especially if you don't see any stones in the gallbladder itself and they're having a right upper quadrant pain. Even with normal lab values, it doesn't necessarily mean you don't have cholecystolithiasis, so that is important to find. A contracted gallbladder also makes it a little bit more difficult to find in that one, it's a lot smaller, so it's more difficult to find. But two, when you have a contracted gallbladder, it can give you a false positive gallbladder wall thickening. And this generally happens because the layers of the gallbladder wall are basically layering up on themselves. So if you see 3 layers, that's not considered pathologic thickening. And then the last one is, we do this pretty often, is misidentification of the gallbladder. So when you're in that area, oftentimes you can actually see the duodenum instead and mistake that for the gallbladder. A lot of people do this because you get that bowel shadowing that I was talking about earlier. Other things that you can confuse the gallbladder for are renal cysts or hepatic cysts. So ways to avoid, or I guess get better views, you can reposition the patient. So if you can't get the gallbladder in view using the techniques I described previously, you can also reposition the patient to get them in their left lateral decubitus position. What this does is it kind of flops the gallbladder over, and then sometimes it helps get it underneath the ribs. Another thing that you can do is have the patient take a deep breath and hold it. This pushes the diaphragm down as well as all the structures underneath it to also try to get it away from the ribs. So about medical decision-making, I'm not really going to go into the management of the individual diseases, but more so why bedside ultrasound is important, talk about the test characteristics and all that. So just briefly, the study by Ross et al. Basically conducted a study to determine the characteristics of bedside ultrasound for cholelithiasis. So what they did is they did a systematic review and basically ended with 8 studies. The studies that they were looking for were using bedside ultrasound detecting sonographic Murphy sign, as well as gallbladder wall thickness and common bile duct thickness. And what they compared it to was CT scan, which we know generally isn't as sensitive as ultrasound, but also MRCP. And what they found from the study is that bedside ultrasound had a 89% sensitivity and 88% specificity in detecting cholelithiasis. And then this next study, so this was another study done by Summers et al., also trying to determine the testing characteristics of both bedside ultrasound as well as ultrasound done by the radiology department in evaluating for cholecystitis. So this was a prospective observational study of about 193 ultrasounds done that were done to suspect cholecystitis. What they assessed for was gallstones, again, sonographic Murphy, gallbladder wall thickness, both in bedside sono as well as the radiologic sono. And they compared it again to CT scan as well as MRCP. And what they found was for bedside sono, the sensitivity was 87%, specificity was 82%. And then for radiology sono, they saw that the sensitivity was 83% and the specificity was 86%. So there's actually no difference between emergency room bedside sono versus like formal radiology ultrasound. I know we still, whenever we see stones in our bedside sono, we end up still sending them for right upper quadrant sonos formally. So some people do. I know we shouldn't because technically with the study there's no difference, but I think the reason that some people still do is because right now we don't have, or surgeons don't have access to our imaging, so it gives them the access. But I think that's about to change. I think we're implementing like orders to do our bedside sono, and that we can actually make a work list, and then soon they'll be able to see our sonos. Is that correct? Perfect. Yeah. So then we can stop sending them to radiology for this. Okay, and then just the last study, just to talk about where we get these numbers from and why there's so much variability. So this study was essentially to understand what normal measurements are of the common bile duct as well as other gallbladder measurements. So they basically took about 4,000 ultrasounds, retrospectively analyzed them, and determined what the normal measurements were. There were wide ranges. So for the common bile duct, they essentially found that the normal diameter was 3.8 millimeters plus or minus 1.6 millimeters. And then for the gallbladder wall thickness, it was 2.6 millimeters plus or minus 1.6. And then they determined what different states were for how different characteristics affected that. So for the common bile duct, they saw variation with age. Basically for each year, there was an addition of 0.2 millimeters. And then for female sex, there's an addition of 0.3 millimeters. And then for cholecystectomy, there's an addition of 1 millimeter. For gallbladder wall thickness, the presence of gallstones increased the thickness by 0.4, sludge by 0.5, and then acute cholecystitis though actually increased the gallbladder wall thickness by 3. So that's just where some of these numbers come from. So to summarize, so just make sure when you're doing the ultrasound that you do it with the appropriate indications. We went over the abnormal findings of ultrasound, so make sure that you're incorporating all that into your test as well. And like the studies described, so our bedside sono has pretty good sensitivity and specificity. So under the right circumstances, you can effectively rule out or rule in a biliary disease with the appropriate like pretest probability. And basically in order to diagnose these various biliary diseases, you need not only the ultrasound, but put it together with the clinical context, your physical exam, as well as lab findings. These are my references. Any questions?
I really like how you highlighted the positive value. Like, all this. I think one thing I really push buttons for is forget about some, I think best various that are afraid to do their own ultrasound are focusing on a small part and not good at it. And so that it's allowing the rest of it because I'm going to get judged on one aspect of it. I'd be happy to see $1 million CBD as long as instead they focus on did I see this on the net, that I really actively transfer that. And then having that sound hurt. And all that positive value is that added to let's say incorporation of is there pain that pushing on this? Then playing all letters, touching it to the wall, stomach, ouch. That's a simple assessment, but unfortunately a lot of times we don't document that. And we start looking at the difference between positive values that one aspect of the exam has so much likelihood that really be confirmed on pathology when they go I guess it was but really it's not which forget CBD, forget come up in zebra cases, but much more relevant is you're really comfortable with how you assess polymorphies and you're really good at pushing your technique to see if there's something okay. Because that one aspect, just in isolation, especially with the mind of the concept, it's so much more relative to patient care.
So for those of you at home, basically Dr. Kilpatrick was saying, forget the CBD. Focus on what you're already good at. If you can't find the CBD, it's not that important, but what is important is to comment on the sonographic Murphy sign, as well as if you see the stone in the neck, that can also help you figure out what exactly is going on. Yeah, Robbie?
Yeah, I guess comment to the question. So it's common to be like other perks of ultrasound, it's like point of stay, especially like patient-oriented outcomes, or even like hospital-oriented, admin-oriented outcomes. So like a place that monitors stuff, you want to move the room. So at some places where you can have a bedside ultrasound that's diagnostic, the surgery will just take the patient. And so I think one of the perks, two perks of ultrasound would be decreasing length of stay and also decreasing radiation for both patient-oriented outcomes. The second question, I feel like a lot of ultrasound studies, one of the issues is like the imperfect gold standard. So
Yeah.
comparing ultrasound to CT, I wonder like why wouldn't they? Are there any studies we come across that? I guess the gold standard would actually be like a tissue diagnosis. So like, are there any studies that looked at diagnosis of cholecystitis on ultrasound, but then they looked at like operative report? That's actually the best gold standard of everything.
Yeah, so I completely agree. Like I mentioned before, when I was going over the studies I ran across, they did compare it with CT scan, which again has not as good sensitivity. So Robbie was saying, why are there any studies that compare it with tissue? Actually, one of the systematic review that I mentioned before, I forgot to mention that they also compared it with tissue, but the issue was because it's a systematic review, there's multiple different things that they compared it to. The specific study that I mentioned, that was like the prospective one, yeah, they didn't compare it with tissue. I think the difficulty with that is that not everyone who has cholecystitis goes to get operated on, so they can't necessarily always do that. So yeah, we don't have a perfect gold standard for these studies, unfortunately.
Hey, the other thing is, you mentioned doing this, avoiding misdiagnosis. Usually 5-9% people with WES Sign see gallstones, biliary colic, even cholecystitis. I had 5-10 visits to the ER, they're all like, no one mentioned anything. There is a lot of discharge. So, you get to the point, feel comfortable incorporating this into your initial assessment. When you know from sign I'm talking. I already know that also or it's a very simple, quick way of avoiding some of the common pitfalls. Nothing else, even the power of hospital pick. I was saying this small. Sending over the stones, you have risk for pathology, a little bit worse, and you feel a fever, you have a much higher risk than that person.
Yeah. So Dr. Kilpatrick was saying that it's a very quick and easy procedure. You can incorporate it in your patients with GERD because it's a pretty missed diagnosis also. So when you're talking to the patient, you can just do a quick bedside sono, incorporate that into your exam, and then you'll know if they have gallstones before even they tell you that they have abdominal pain. Thank you.